So what will be the more common causes that will cause men to be infertile or have an infertility issue caused by men versus women?
So there are obstructive causes. So when the sperm is made in a testicle, it travels through the vas deferens, the epididymis, and then out the ejaculatory duct. So there can be obstruction in that system. There could be non-obstructive causes. Those include things like poor production of the sperm. There's nothing wrong with the tubal system, just the production's not as good. And then there is kind of a bigger category where it's called OATS, oligoacetoteratospermia. So it means low count, low motility, low morphology, and many times those can be treated with medications, with seeing a urologist who takes care of men with infertility.
Gotcha. About different health topics every week. We do so by bringing on medical experts to answer commonly asked questions. Be sure to send in your questions through Facebook Live on Wednesdays at 5 p.m. You can find more information about our show on Facebook, Instagram, Twitter, and YouTube. And of course, our website, doctalklive.com. That's DOCTALK live.com. Also, watch more episodes on platforms such as Spotify, iTunes, and iHeartRadio. Again, guys, my name is Dr. Sylvie Simon, and I am hosting today's show, which I'm very excited about. So some statistics. Did you know that about 12% of women aged 15 to 44 years old in the U.S. have difficulty either getting pregnant or carrying that pregnancy to term? So with that, I would like to welcome our infertility specialist, Dr. Dorette Nurhazen, here on our show to discuss a very important and very common topic of infertility. Dr. Nurhazen, thank you so much for being here on our show. Please do tell listeners about yourself and your practice.
Thank you, Dr. Simon, for that wonderful introduction. A little bit about myself. So my name is Dorette Nurhazen. I'm a reproductive endocrinologist and infertility specialist here in the Dallas-Fort Worth area. I've been in private practice now for a little bit over 12 years, and practicing fertility care for patients is a passion of mine. So I went to medical school at Boston University School of Medicine, did my residency here in Texas, and yes, that's why I love Texas, and a fellowship in New Jersey, and I've been in private practice here now since then. Infertility is such a passionate subject of mine. One, because I really enjoy doing this. I really enjoy taking care of women and helping families grow. But there's a personal aspect of it as well for me. So I met my husband much later in my reproductive years, and together we had problems having a child. So I have personally undergone 5 rounds of in vitro fertilization. That is 5 rounds of taking 3 to 5 injections daily for about 2 weeks, 5 egg retrievals, and out of that entire process, I got 1 euploid embryo. So 1 embryo that tested normal on genetic testing. And that embryo was transferred to a surrogate. And because of my surrogate's kindness, I'm a mother today. So all the things that I offer my patients, the diagnostic testing, the treatment options, I too have personally tried them on myself. And that's how I know they work, and want to share my experience as both a professional and also my personal experience of what it's like to undergo fertility treatments with our listeners today.
Thank you so much, Dr. Nurhazen, for sharing that, and especially your personal aspect of how you dealt with all of this, and being here again to share with our listeners and educating them a little more about infertility. So starting off, can you explain what it means, what infertility means, or how is that diagnosed?
Oh, that's a great question. So infertility is diagnosed if there's a female partner age under 35, if she's been trying for a year or longer to get pregnant and not successful, she has a diagnosis of infertility. But if she's age 35 and older, then trying for 6 months or longer without success, and then she meets a diagnosis of infertility. And the reason why that age 35 is such a cutoff is that we define age 35 as advanced maternal age or advanced reproductive age in a woman, where we see decreased chances of getting pregnant and increased chances of miscarriage. And so that's why we're using age 35 as the cutoff. But there are other couples that will see me right from the very beginning without even trying 6 months to a year. And those couples include men and women who've had previous tubal ligations or vasectomies and are now on their second marriage. Also, couples where the female does not ovulate. She has a history of irregular cycles. She knows she's going to need my help from the very beginning. There are also couples or members of the LGBTQ population that will need my help from the very beginning. So those patients will see me from the get-go to try to help them get pregnant.
And is there any special diagnostic tool that is used to diagnose infertility, or is just the criteria that you mentioned?
So great question. So when a patient presents to me, the first thing we do is get a thorough history, find out why they're having problems conceiving. We do a thorough physical exam. And then there's a series of testing. The testing includes ultrasounds. There's a histosalpingogram, sometimes called an HSG. That's a dye test where we inject dye from below and see the dye fill the uterus as well as the fallopian tubes. And then that's way we know that the woman's tubes are open. The husband will undergo a semen analysis where we can analyze the sperm count as well as the motility and morphology, that is the shape of the sperm. And so we're getting a good idea as to sperm quantity and quality. And then based on those testing results, treatment recommendations are given. Now, there's about a 50% chance of, so 50% of the time we find female factors, meaning the factor is in the female partner and that's why they're not getting pregnant. But believe it or not, 50% of the time it's a male factor. And traditionally, people always thought it was just the woman's fault why she wasn't getting pregnant, but there is truly a male component as well.
That's interesting. That's a shocking number, actually. I didn't know it was 50%. Males can also contribute to infertility.
Yeah, so when we find causes, 50% of the time it is male. And the other interesting thing is 20% of the time we don't find a cause. So we do all the testing, and the testing is normal. And we call this unexplained infertility. And these patients with unexplained infertility will still go on and have healthy pregnancies with some form of treatment.
And so what will be the more common causes that will cause men to be infertile or have an infertility issue caused by men versus women?
So there are obstructive causes. So when the sperm is made in a testicle, it travels through the vas deferens, the epididymis, and then out the ejaculatory duct. So there can be obstruction in that system. There could be non-obstructive causes. Those include things like poor production of the sperm. There's nothing wrong with the tubal system, just the production's not as good. And then there is kind of a bigger category where it's called OATS, oligoacetoteratospermia. So it means low count, low motility, low morphology. And many times those can be treated with medications, with seeing a urologist who takes care of men with infertility.
Gotcha. And likewise, what are there more common causes why women would be causes of infertility?
You know, the most common cause that I see, and remember, I'm seeing a skewed population. I'm seeing patients who cannot get pregnant. So the most common cause that I see is advanced reproductive age. So women, we're born with all the eggs we will ever have, and we lose the quantity as well as the quality of those eggs with time. So as we advance in reproductive age, so past that age 35, it becomes more and more difficult for us to have babies. And that's the problem that my husband and I faced. Actually, my husband's also older too, so we had both those problems. So the most common cause I see in women is a lower egg reserve, meaning a lower quantity and quality of eggs with advancing reproductive age.
And again, you brought your personal kind of experience and how Dr. Nordhausen has gone through all of this herself. How has that experience changed how you practice and your overall practice?
It certainly has changed the way I practice medicine. I totally understand what it's like to stand in my patient's shoes. I can see it from both sides of the exam table. There is a roller coaster ride that our fertility patients undergo where they get their hopes up thinking that this is a cycle that's going to work and everything's going to be okay.
Right.
And those hopes come crashing down a couple weeks later when you realize, well, you're back to square one and it didn't work. And, the hardest part about all of it is finding the stamina, the courage to get back on that roller coaster again and going for another ride.
Mm-hmm. And you shared you've done this
5 times.
5 times. Oh, a lot of stamina. Okay. And so other aspects that can affect infertility, how about mental health? How important is that?
Yeah, so mental health and infertility are intertwined so tightly, it's very difficult to tease them apart. Mm-hmm. And it seems that there is a vicious cycle with mental health. So we do fertility treatments, it doesn't work, and then the person gets more anxious, more depressed, which then affects their ability to respond and do well with the next cycle, and it becomes a vicious circle. What I tell patients is to find support groups. One of the biggest things is knowing that there are other people struggling with infertility. You mentioned it at the beginning of the show. 12% of patients struggle with infertility. Yeah. I mean, 1 in 8 struggle with infertility and 1 in 4 with miscarriages. There are people walking around right here that have problems having a child. And so finding a support group is incredibly important to know that you're not alone. There are lots of Facebook groups, there are lots of online groups, there are even lots of local groups where women and men get together during the weekdays in the evenings and talk about their experience, and that's very helpful. Some patients find it helpful to speak with a therapist, and occasionally some patients may need medical treatment in terms of medications.
Yes. So let's get a little bit into treatment and what is the solution here? I know obviously you are a shining example of that there is hope and there is definitely a baby that can come. So tell us a little bit about services that are available in your office or in this whole world of infertility.
Absolutely. So one of the simplest forms of treatment is ovulation induction. So taking medications to induce ovulation and having a woman release the egg and then timing that release of the egg with intercourse. So ovulation induction, we could do so with pills. So clomiphene citrate or letrozole are 2 oral medications that we'll typically prescribe for this. We could also induce ovulation with injectable medications, gonadotropins, and those will induce ovulation. Now we can time when the egg is released with either timed intercourse, telling a couple when to have intercourse, or intrauterine insemination, sometimes called artificial insemination. So what that means is the male gives us a sperm sample, we wash it, we spin it down, and we concentrate it, and then we put it directly into the uterus. This is no more exciting than a pap smear. So it's done in the clinic, speculum exam, that's it. You don't have to have anesthesia, anything like that. And we put the sperm directly into the uterus with intrauterine insemination. And by doing so, 1, you've bypassed the cervical mucus where the sperm can get trapped. And 2, by putting it directly into the uterus, you shorten the distance that the sperm has to swim to the egg, and therefore increasing the chances of pregnancy a little bit more than just timed intercourse. So that's the simplest form of treatment, ovulation induction with either timed intercourse or IUI. The more advanced form of treatment is in vitro fertilization, IVF. And it's not a stepwise pattern. Sometimes the testing shows that you need to go directly to IVF and don't have to do ovulation induction or IUI. And sometimes your testing may be normal and you may choose to go directly to IVF. So let's talk about IVF.
Yes.
IVF means that the woman would take injections, typically for about 1.5 weeks to 2 weeks, and that helps her ovaries produce the eggs.
Gotcha.
We then retrieve the eggs. That's done under anesthesia, so you won't feel or remember the process. It's all done vaginally, so there are no incisions on the belly. We retrieve the eggs. We give the eggs to our embryologist, and then the embryologist will fertilize the eggs with the sperm that same day. Now, the embryos will grow in our lab in the incubators for about 5 to 7 days. 5 to 7 days later, it's called the blastocyst. So it has a lot of cells where we can see the trophectoderm. That's the part of the embryo that will become the placenta. And then we can see the actual embryo.
Wow.
At that time frame, we can freeze the blastocyst, many patients will choose to do genetic testing of their embryos prior to freezing the blastocyst. So that's called PGTA, Pre-Implantation Genetic Testing Aneuploidy Screening. Some facilities like ours call it CCS, Comprehensive Chromosomal Screening. But that's a general aneuploidy screening. So that's testing your embryos for Down syndrome, Turner syndrome, trisomy 16, trisomy 18, monosomy X. Genetic causes that can lead to miscarriage or failed implantation, so not even getting pregnant.
Gotcha.
The other type of genetic testing that you can do is called pre-implantation genetic testing, monogenic or monogene, meaning searching for a specific gene. Now, the PGTA testing can be done in any couple despite their genetic makeup. PGTM testing is specific for that couple. So, for example, let's say both the husband and wife are carriers for cystic fibrosis, which is an autosomal recessive disorder, meaning you can be a carrier but don't have the disease. But if two carriers try to conceive together, you have a 25% chance of having a child with the disease. We can test the embryos for that specific couple for the cystic fibrosis gene and then transfer an embryo that does not carry the gene. Or, for example, the BRCA gene, the BRCA gene, that gene has been associated with breast and ovarian cancer. We can screen the embryos for that gene if the woman or man carries the gene and transfer an embryo that does not carry the gene. Therefore, improving the health of that offspring. They probably will never have to have a mastectomy or oophorectomy, meaning taking out their ovaries or removing the breast tissue. So that's very, very helpful for patients.
When should you actually get genetic testing? I guess it's based on the parents or what they have, or is this kind of everybody that's going through IVF will get genetic testing?
That's an awesome question. So yes and no. So it could be based on the parents. So if they say, several members in my family have breast and ovarian cancer, we're going to screen that woman or man for the BRCA gene and other genes. And then if they are carriers, then we'll screen the embryos. But then there's also, we do a generalized, what's called genetic carrier screening. And the genetic carrier screening for the woman and man, that's a generalized screening test for recessive disorders, meaning you can carry the gene but never have the disease. And because you don't have symptoms of the disease, you don't know you carry the gene. And so I used the cystic fibrosis example earlier on. So we can test both the man and woman for that. And then in the embryos, if the couple chooses, they can do the CCS testing or the PGTA testing, the generalized aneuploidy screening of their embryos, which will drastically improve their IVF pregnancy success rate.
Yes. Well, IVF, that word is thrown out very commonly these days. And I know several people who have gone through in success stories and, their miracles. And it's amazing. But how accessible is it? As in, does insurance cover it? How expensive it is? Can you explain to our audience a little bit how that works?
Absolutely. Because the awareness, we're having more and more awareness of infertility and people are sharing their stories. Fertility treatment coverage is becoming more and more accessible for patients.
That's awesome.
I will tell you, about 95% of my patients who have insurance have diagnostic testing coverage. And about 50% actually have treatment coverage. So it actually is becoming more and more accessible. I would tell patients to contact their HR departments, get an explanation of benefits, just to have an idea of what's covered and not covered.
And are there, and this is, you said kind of on a variety of insurances that you've seen in your practice that cover it?
Yeah, so at our practice, we are a center for excellence with insurances like United Healthcare and Aetna. And that means that it costs patients less to see us because we're seen as a tier 1. We have excellent pregnancy success rates, lower complication rates. So definitely insurance can certainly influence your decision to pursue treatment.
Definitely. And, what's been going around for the last almost 2 years is COVID, right? And the pandemic.
Everyone's favorite topic,
Everyone's
COVID.
favorite topic. And, of course, COVID does not, the topic of COVID does not evade infertility either. But can you tell us if there's any relationship with getting the COVID vaccine, or the virus itself, first of all, and infertility? And then, of course, I'm going to ask you about the vaccine and the safety recommendations on that regarding infertility.
Absolutely. So it seems that COVID is here to stay for quite some time. Yeah. And there is, I will tell you, someone who has gone through life, medical school, residency, fellowship, they never felt like there was a perfect time to do anything like having a child. Right. And so there'll never be a perfect time to do this, and we can't sit and wait for COVID to be over. Right. So you just want to take safety precautions, wear a mask. In terms of the vaccine, there is a rumor out there that the COVID vaccine causes infertility, but it does not cause infertility. I advise my patients to get the vaccine. And I get it. COVID is a new disease. It's only been around for a year and a half. The vaccine is even newer. And it's scary because you don't know what to expect. And you feel, as a patient, you feel like the data changes every day and it's something new every day. But this is what I tell patients. What you want to do is just boil it down to the risk and benefits. Right. Is it more dangerous to get COVID disease when you're pregnant and pass that disease on to your unborn child, and we don't know the effects of what that can be on your unborn child? Or is it better to just get the vaccine? Yes, you may have a day or two of flu-like symptoms, but then it's over and you already have the antibodies prior to pregnancy. And for most patients, that means getting the vaccine.
Right. And interesting point, I did not know this before this discussion, but it seems you have written 2 books, correct, about infertility. Can you tell us a little bit about your books?
Oh, absolutely. So my first book is called Miracle Baby, A Fertility Doctor's Fight for Motherhood. And I will tell you, I'm a very personal, I keep my history very personal, and it's all about sharing your information, because the more you share, the more other people know that they're not alone in their journey. And so I told myself, once my son was born, and I did this in between diaper changes and feeds, I started writing. I sat on my computer and started writing. So Miracle Baby is my personal journey to motherhood and all the struggles that I went through to have my child. There's a second parallel story, though, in the book. The second story is my own personal life story, and so it goes through details of my humble beginnings as an immigrant and then what it's like to be a successful physician. When you read this book, you will have hope, you'll have faith, you'll laugh sometimes, you'll cry at other times, but at the end of the book, you'll leave the book feeling good, and it's a good inspirational story. The second book that I wrote is called The Fertility Manual, Reproductive Options for Your Family. So this book, what I've seen over the years, and I'm sure you see this in your practice as well, sometimes as physicians, we speak medical terms all the time and we forget to break it down into simpler terms. Yes. So what I wanted to do was write a book with just basic infertility, just giving the basic information. And it's simple, it's easy to read, it's less than 100 pages. But the purpose of this book is to equip patients with the knowledge they need to go to their doctor's office and ask the right questions. I will tell you, my husband read the first draft of both of these books. And when he read the first draft of the Fertility Manual, Reproductive Options for Your Family, he said, I wish someone gave me this book before we started this fertility journey, because he's not in medicine, and and he has access to me. He could wake me up at 2 a.m. and ask me a question if he wanted to. But he felt like he was alone in the process and still didn't understand all the facts and had to rely on me to make the decisions for everything. And he didn't feel equipped enough with the information. And so he said, anyone who's going through fertility really just ought to read this, just to get some general bearings as to the fertility.
Gotcha. That is awesome. So congratulations on all of your success and you just helping other people. But tell our listeners, how could they find you?
Oh, absolutely. So I'm on all forms of social media, Facebook, Instagram, and Twitter. My handle is just at DoretteMD, so at DoretteMD. LinkedIn is just my name, Dorette Nurhassen MD. I last year with COVID and the shutdown, I started creating educational videos. So I started my own YouTube channel where
Oh,
I've
awesome.
posted numerous educational videos, and my YouTube channel is Fertility Dr. Dorette Nurhassen. You mentioned my books earlier on. Those are at my website, www.noorhasan.com, so just my last name. But more importantly, if you are struggling with infertility and you want to become a patient, definitely reach out to my office. Our number is 972 377 2625.
Thank you so much. It has been such a delight and informative having you here, Dr. Dorette Nurhassen, and wish you continued success and for your patients. Believe it or not, guys, we are at the end of our show. It was a pleasure being here with you guys. Please do check us out on our website and also on our social media on Facebook, Instagram, Twitter, and our website, doctalklive.com. We will be back with you guys next week. And until then, please do stay healthy. And this is Dr. Simon signing off. Thank you.